Welcome to the JET ISR. Welcome to the JET ISR Angiography and Ultrasound Core Laboratory Protocol Training. This is Dr. Banerjee. Thank you for joining. The outline for our discussion today includes Angiography Protocol and Duplex Ultrasound Protocol. Let's start with Angiography. The XLPAD Core Lab Protocol, or CLP, is designed to adjudicate study angiograms and duplex ultrasound studies performed as per the protocol of the study based upon eligibility criteria defined in the protocol. And therefore, this document is only a companion to the main study protocol, and the JET ISR study protocol supersedes all criteria and conditions listed in this CLP. Regarding peripheral angiography, cine angiography, or DSA, or digital subtraction angiography, image runs of the target femoropopliteal instant restenotic segment of pre-existing metallic, however not covered PTFE stents are included in the study, and therefore there should be no or minimal overlap with underlying bones when these images are captured, and also with minimal or no motion artifact and in an anterior-posterior projection. Orthogonal or near orthogonal projections are at the discretion of the operator. As you can understand, if you are looking at stent fractures, and orthogonal projections might be important. However, it might be difficult and not routine. So whatever you do at the beginning of the procedure needs to be repeated at the end of the case. Optimal contrast density to pacify the vessels of interest. A presence of a radio-opaque ruler beside the target lesion with no overlap with the target lesion, preferably adhere to the inner aspect of the thigh across the popliteal fossa, is important. I think the next slide will illustrate why. Visualization of the sheath or on imaging runs whenever possible is highly recommended. We use a catheter or the sheath for calibration. Contrast type and dilution will be at the discretion of the operator. However, the target vessels need to be fully and optimally pacified without streaming artifacts. And selective angiography of the artery with image of the sheath or a catheter used for contrast injection is always preferred. Imagine you have done the angiography and your duplex ultrasound tech has to do follow-up duplexes. He or she will have a hard time identifying the target treatment segment within a large stented length. And therefore, if you use your ruler and provide them with the distance from mid-patella to the distal and proximal edges of the target lesion that has been included in the study, it will help them replicate that using a tape while doing this duplex ultrasound examinations and identify the target lesion. I hope this is clear, and this figure on the screen illustrates this. The femoropopliteal ISR target segment should be captured in one image frame whenever possible, along with 10 mm segments proximal and distal to the target lesion. In the event the entire lesion is not captured on a single frame, overlapping images of the target lesion ISR segment with a radio-opaque ruler in view should be captured. The dimensions of all prior stents implanted in the target vessel and lesion should be provided whenever possible, and there's a worksheet that is going to accompany the protocol sent to you from the core laboratory. And angiographic and DSA of the entire femoropopliteal artery should be provided. Height of the table and image intensifier should be kept constant with capture of radio-opaque ruler and or a catheter for image calibration. This is required to determine reference vessel segment. Static frames, preferably non-DSA images of the target lesion ISR prior to any intervention without any underlying bony artifacts is needed to determine the type of baseline stent fracture. It is very important that we capture these cine angiographic views and images without DSA, because on DSA stent fractures are hard to determine. Static image frame, again preferably non-DSA, of the lesion without bony artifacts are needed at the end of the treatment, again to see if there are any new stent fractures after ISR segment is treated with the jet atherectomy device. Angiographic or DSA image runs of below the knee vessels are needed, at least at the level of the ankle, and before and after target lesion intervention. You can understand this is to identify if there is any distal embolization. Index procedure angiographic images will also be utilized to determine reference vessel diameter, lesion length, severity of stenosis, as I explained, types of stent fracture, if any, and post-procedure success of treatment, types of restenosis, if any, and presence or absence of distal embolization. Size of pre-existing metallic stents in the target femoropopliteal artery should be provided to the core lab if available, because that will be used for us. This information will be very useful for us to determine analysis and also the dimensions of the reference vessels. In the presence of overlapping stents with different stent diameters, we will use the reference closest to the stenosis. In addition, all participating site investigators will have to complete this online module for training and submit also a CD/DVD of both angiography and DUS and for verification prior to initiation of any enrollment at your sites. To summarize, we need three kinds of images. Remember the abbreviation PAF. P stands for plain film angiography, or A stands for angiograms of the lesion before and after the lesion is treated, and F stands for foot angiograms at least to the level of the ankle to determine distal embolization, again pre and post intervention. So you need to do PAF pre-intervention and PAF post-intervention, and if you can just stick this into your cath lab, I think this will be a good reminder for all of you up at the sites to acquire the necessary minimal images. This is an example. You can see the plain cine film onto your left showing the stent fractures, then the angiogram of the lesion. You need to capture this before and after. The reason I chose this because the ruler has been placed right on top of the lesion. Try to put it beside the lesion, preferably not on top. And then the foot angiogram for assessment of distal embolization, at least at the level of the ankle, but foot angiography is highly acceptable. Once you submit your angiographic CDs to the core lab, you'll receive a quick response in 5 days telling about any quality issues or other events that we detect on the angiograms. There's also a core laboratory contact information that is for you to use. If you have additional questions, feel free to email us. We will again resend or recontact you, and again hold personal sessions to answer any questions. There is an emergency after hours, a weekend contact number. That's a cell number or a mobile number. I envision there rarely some patients could be enrolled on a weekend. However, that is a number for you to use and contact us. All images for the angiogram and for the DUS, of course, will be sent to us in a DICOM format on a CD or DVD labeled appropriately. Please don't use adhere tapes accompanying and use the accompanying CLP form 1 for angiography and 2 for DUS, and it need to be mailed and the address is provided on these forms. So thank you for the angiographic part, and let's move on to the ultrasound part or duplex ultrasound protocol training. Again, there will be 3 ultrasounds, one within 45 days post-procedure that will be labeled as index DUS, and then a 6-month and a 1-year follow-up. You can use any contemporary DUS machine approved at institutions. Again, the transducer should operate at the highest clinically appropriate frequencies. Anything above 3.5 megahertz or greater is acceptable. Again, the recordings have to be in a DICOM format. Equipment gain and display settings should be optimal with respect to depth and dynamic range of the images, and also color flow Doppler should be added to supplement B mode images that is necessary, and power Doppler could be used to validate low flow states or in the presence of occlusions. The cursor sample size is a very important issue, as you all recognize, and it should be small and positioned parallel to the vessel and or in the direction of the flow. A spectral Doppler angle of 60 degrees or less will be used to measure velocities, and the spectral Doppler gains will be set to allow a spectral window and optimize to reduce artifacts. Areas of suspected stenosis or obstruction should include spectral Doppler waveforms and velocity measurements recorded at and distal to the stenosis obstruction. More details on this is present on the CLP form 2 that tells the sonographer exactly where those measurements need to be made, and please follow those guidelines carefully and fill in the table present on the form. Sites of intervention, that is the stent in this particular case, will include spectral Doppler waveform and velocity measurements from proximal, mid, and distal sites. Again, remember from the angiographic section, I showed you how the location will be confirmed by the ruler. Plaque should be assessed and characterized, identify, and use color Doppler for proper assessment of vessels and measure PSVs and and diastolic velocities wherever applicable. Every 30 millimeter, that's recommended. However, the CLP form again shows you which are the minimal required measurements that need to be made in a valid post-procedure study. Label all vessels accordingly to anatomy. I think it is important that the guidance provided in the CLP Form 2 are strictly followed, because mislabeling or using incorrect labels can confuse the analysis at the core lab end. In patients with significant femoral popliteal artery stenosis or occlusion, a flow into the popliteal artery should be examined. And again, the minimum requirements are proximal, common femoral artery, superficial femoral artery, and popliteal artery distal to the stent if the stent is in the mid or distal SFA. This is a repetition of what we have spoken before, but again, this is a reminder that angles of 60 degrees or less will be acceptable. Again, calculate the PSV ratio. Cross-sectional or longitudinal residual diameter measurements with or without the use of CDI are notoriously inaccurate and do not correlate well with contrast angiographic images. And spectral Doppler waveforms and velocity measurements must be documented from the 3 locations that I told you. And again, the form that will be the worksheet has accurate and detailed instruction for where these measurements should be made in reference to the target lesion. For good quality DOS examination, apply heel to toe for 60-degree angle measurement. Doppler of sample volume should be through entire course of the vessel. Obtain measurements every short distances. Again, I ask you to refer to the CLP form. This is just for guidance, and for transverse B mode, use 90 degrees between vessel and the beam. Some of the common mistakes associated with the DOS examination are mentioned here: incorrect angulation, mismatching of blood vessels with labeling, low quality images, incomplete worksheet, and no grayscale image. All can confuse the core lab and make the study not usable. Again, all images need to be transferred to us for analysis in a CD or a DVD in a DICOM format, appropriately labeled with the accompanying CLP form. Again, CLP form 1 is for angiographic CDs, and CLP form 2 is for a duplex ultrasound. The core lab contact information is shown here. We could be contacted by email, but also if you need to call us, the core lab technical director can be contacted at this number, and for weekends and emergencies, a cell number and mobile number is provided. I can't imagine a follow-up duplex ultrasound study on a weekend, but however, if you need to contact us on a weekend or after business hours, please use the second number, 9728905375.